viewers. The next session is on Where Are We with Closed Loop Ventilation by Professor Marcus Schultz. So, Sir is a distinguished professor of intensive care medicine at the University of Amsterdam, an intensivist and principal investigator at Amsterdam UMC, and honorary research fellow at the University of Oxford, UK. He is the founder of the Prof network, Crit Care Asia and Crit Care Africa, and serves as a global advisor across Southeast Asia and Africa in establishing research protocols. With over 1,200 publications and an H index of 128, he is among the most cited critical care researchers worldwide and has led more than 60 clinical trials. He is a former co-chair of the Laboratory of Experimental Intensive Care and Anesthesiology and is widely recognized as a pioneer in protective ventilation and global intensive care implementation. So, Professor Schultz, sir, it is a great honor and pleasure for us to hear from you, for us to have you on our symposium. Thank you very much, sir.
Well, thank you very much. The honor is all mine, I should say. It's really a pleasure to be in this meeting and especially in this session. And I really like to talk about the topic that you gave to me, was the question, where are we with closed loop ventilation nowadays or at this time? I've worked with closed loop or automated ventilation for almost my whole career, for 35 years in the ICU. And I will show you some of my experience and also show some of the work of our group and of others. I hope you can all see my slides now and also see it moving. I have no disclosures with regard to this meeting, but I have to say that I worked for Hamilton Medical in Switzerland. It's a medical device company which makes ventilators that have IntelliVent ASV or ASV on their devices, but it's not influencing what I'm going to say today. The agenda of this presentation is as follows. I will first talk a little bit about the background, then I will discuss effectiveness and efficacy, and finally we'll discuss some of the future steps we are going to take and also the future of automated ventilation in general. But before I dive into the background, let me explain what I mean with effectiveness and with efficacy. So when I'm talking in this lecture about effectiveness, I actually talking about how well the automated system or closed loop system is performing the task. So for instance, if I want a ventilator to choose or adjust the tidal volume within a certain range or within a certain target, how well does the ventilator perform that task? That is what I mean with effectiveness. So it's more a technical or operational performance of, in this case, automated ventilation. When I'm talking about efficacy, I'm actually talking about how well the automated system affects patient outcome or patient level outcomes. For instance, you can ask the question, does it reduce the time a patient is on a ventilator? Does it improve extubation prediction? Does it improve the survival of our patients? So here I have a different meaning. This is really what we want to know at the bedside. How well is the intervention helping our patients? And there are some other aspects, but I'm going to discuss this a little bit later on. So stay tuned. I will add some extra information to this later on. So let's go back to the agenda. This is, again, where I would like to start. Why do we want to have automated ventilation? And I apologize a bit for this busy slide, but I will walk it through with you clockwise. So when we start on the right upper corner, the main question is, why do we want to have this? Well, we all know, you all have the same experience. Setting a ventilator seems easy, but it isn't. You have to take many things into your mind. You have to be aware of many things, as already discussed in previous presentations, especially Giacomo was mentioning this. So how can the ventilator, or better said, the closed loop globe, help us in this respect? I already spent some words on, and now I go clockwise a bit further, about effectiveness and about efficacy. There is not so much on safety, unfortunately, if you look into all the studies and the study results, safety is not so well reported, and it could be that it's not even looked after. But I will give you an overview of some of the information we have at hand in the literature at the moment. And there is something what I tend to call the workload associated with mechanical ventilations, and that's workload of nurses, that's workload of doctors. And is it possible with a closed loop mode to reduce that workload? We all think that's important, and it's getting more important with the growing numbers of patients in our ICU, but also the reducing numbers of nurses is especially a problem in the Western countries in Europe, where doctors and nurses are getting more sparse over the last years. And finally, we have to be aware, and this is actually one of my conclusions as well, we have to be aware that our responsibility with regard to the patient does not change. We stay responsible for the patient, but our role may change. We are more in the position of a pilot overviewing or taking care of what an autopilot is doing, but we stay at all times responsible. So what do we know about effectiveness? Laura Buitenman published this nice overview a couple of years ago in intensive care medicine, showing all the possible or the major automated forms of mechanical ventilation which are out there. And as you can see, it already started some 20, 30 years ago with PAV and later on PAV plus. Then adaptive support ventilation came into play. That was the mode I started to work with. That was the time I became an intensivist. We had NAVA and still have it in some of our units. Smart Care came a little bit later. I have to admit, I do not know too much about Smart Care. I have no experience with this automated mode of ventilation. And finally, we have Intelligent ASV. And they do more or less the same. They monitor something and they take action on that. For instance, PAV Plus is monitoring flow and volume. ASV is looking at the best combination of tidal volume and respiratory rate, and will adjust it according to the least work of breathing. It's called the Otis equation. NAVA is monitoring diaphragm activity and is then applying an inspiratory assist in proportion to the diaphragm activity. SmartCare is combining different input coming from the ventilator, like monitoring tidal volume, respiratory rate, and tidal CO2, and is then stepwise reducing the pressure support and perform SPTs. And Intelligent ASV, and I think it's the most sophisticated one. Actually, it's a follow-up of ASV. It's doing exactly the same as ASV, but it now also adjusts the tidal volume and respiratory rate to the lowest force of breathing using the MEAT equation. And it's monitoring tidal volume, respiratory rate, and tidal CO2, SpO2, and it's then automating titrating minute ventilation with PEEP titrations and FiO2 titrations. I will focus in this presentation on these three forms because most of the literature out there is on these three forms. I'm not saying that NAVA is not important or SmartCare is not important. It's simply that there are less studies available, and I want to keep my presentation on what is mostly published on. So if we focus on PAV+, in PAV+, I think the word proportionality is important. It's actually titrating the work done by the ventilator to what the patient is doing based on the mechanical load, which is respiratory system resistance, respiratory system elastance. And then it's depending on how you set the percentage of assist, determining how much is delivered by the ventilator and how much is done by the patient. And this support adapts in real time. And it's claimed that it's preventing or reducing asynchrony, that there is a better matching of neural and ventilatory timing related maybe to this asynchrony, that you have more physiological tidal volumes. I will show you some data on that, and that it improves the comfort of patients. One limitation, or it's not really a limitation, but compared to other automated forms of mechanical ventilation, it is a limitation. It's only active when a patient is active. So when the patient is moving into a phase in which she or he is actively breathing. And I think this is one of the nicest studies. It's a small study. It's not an efficacy study, but more an effectiveness study. In this study, you can see how the ventilator behaves if you have an ARDS patient that is switched from volume control to PAV plus with regard to tidal volume changes and driving pressure changes. It's again a bit a busy slide, but let me explain what you see on the left side and what you see on the right side. What the left graph basically is showing that if the compliance of a patient, the respiratory system of a patient is increasing after the switch, it is increasing the tidal volume size. It's, by the way, still a relative low tidal volume. It's not exceeding the thresholds that we usually have, like 8 milliliters per kilogram predicted body weight. But it is increasing it. On the one hand, you can say this is maybe not what I want, but actually, this might be a good solution if there is more space for the tidal volume. If you have a more compliant system, then tidal volumes can increase. Now, let's look at the right side of this slide. And there you can see what happens with the driving pressure. Interestingly, these changes in tidal volume are related or associated with changes in the driving pressure, where patients with a low driving pressure at start are allowed to ventilate with a somewhat higher driving pressure. So on that side, you see an increase. But patients that start with a high driving pressure are getting or receiving mechanical ventilation with a lower driving pressure at the moment PFE plus starts. So this is how I think I would respond to the bedside. And it's nicely shown here that this automated mode of mechanical ventilation is actually doing this. Now, let's forget about ASV and jump immediately in IntelliVent ASV, the most sophisticated or more sophisticated form of ASV. So with IntelliVent ASV, you have actually two domains. There is on the one hand the ventilation domain and the oxygenation domain. The ventilation domain is looking at the best combination of tidal volume and respiratory rate, resulting in the best minute ventilation. And the oxygenation part is looking at the best FRO2 and the PEEP level. And using these two formulas or equations that I already referred to on one of my previous slides, the Otis equation and Mead equation. I will not discuss this in detail because we do not have time for that. And it is claimed that with IntelliVent ASV, the patients are kept in more protective ventilation ranges over time, that it reduced the number of adjustments made by the caregivers, by doctors and nurses, so manual adjustments, that this results in a lower clinical workload. It's also claimed, but we have to discuss this a little bit later on, that it improves synchrony and comfort of the patient, and it enables the smooth transition from controlled to assist ventilation. And this is exactly one of the opportunities as compared to PAV+. It starts from ventilation, so intubation, to the bitter end, which is the extubation of our patients. The patients do not need to be active to have the system work. And actually, most of the activities done by IntelliVent ASV is in the phase the patient is more passive. So what do we know about the effectiveness? This is results coming from the positive study. Again, apologies for this busy slide, but basically it shows how the ventilator behaves when the patient is after cardiac surgery in the ICU, weaning for mechanical ventilation. Every breath with mechanical ventilation was scored according to 4 determinants, which was tidal volume, the maximum airway pressure, the SpO2 level, and tidal CO2 level. And it was scored as an optimal zone, or breath being in the optimal zone, or an acceptable zone, or a critical zone, meaning that the breaths were in some or the other way bad, like a high tidal volume or a high pressure or SpO2 out of target. And what you can see here on the right side is the number of breath and the percentages of breath or proportion of breath in the optimal zone, on top in the automated ventilated group, and on the bottom the conventional group. And you can see that the optimal zone, the breaths are more in the optimal zone with automated ventilation, and there are less in the acceptable and even less in the critical zone. So the ventilator, or IntelliVent ASV, is performing a quite good job compared to standard of care. And this is quite soon happening. You can see here in the graph in the middle or on the left side how each patient behaves. Every horizontal line is a patient, and the colors correspond to what I showed you on the right side. And you can see in the patients on top, the automated group, that the color turns from red to yellow and immediately green very soon after start of mechanical ventilation, while it takes time with conventional ventilation, so it's faster. And it's keeping patient more in the optimal zone as compared to conventional ventilation over the first, here I show 3 hours of mechanical ventilation, which is more or less the time these patients are on the ventilator. So trying to translate this visual presentation of the data into another study. This is the BRAVE study, recently performed in Italy by Dutch and Italian investigators. Here we looked at the performance, the effectiveness of intelligent ASV in neurocritical care patients, where you of course can score each breath in the same way. But realize here that with regard to end-tidal CO2 and SpO2, now actually you have two risk zones. Too low and too high is bad in both for both parameters. But again, if you look at how automated ventilation performs, and apologies for flipping the figure around, here you see now in red critical, which is more on the right side, and optimal on the left side. With automated ventilation, breaths are more often in the optimal zones as compared to the critical zones, and are more often in optimal zones as compared to conventional ventilation. So again, it's a signal that the effectiveness is good. Now you might say, these patients are not too difficult to ventilate. What about ARDS? Well, with ARDS, I do not have such nice figures, but I have some other figures coming from a small study in which we use an esophagus pressure measurement to be absolutely sure to measure what we want to measure in these patients to get an idea how well the ventilator performs. Here you see actually the same thing happening, but there are two things that are of importance, maybe even three. The tidal volume slightly increase. That's what you see in the figure on top left, while respiratory rate dramatically decreases. And this is because intelligent ASV is also more or less accepting permissive hypercapnia. It's not really permissive hypercapnia, although in severe ARDS, it is truly permissive hypercapnia. But even in patients not having ARDS, you see that the ventilator is constantly pushing the boundaries of CO2, accepting higher CO2 in these patients, resulting in a lower respiratory rate. And if you do the calculation, if you do the math, you know then that the mechanical power in these patients will be lower. And this is exactly what we, of course, expected. The lowest force of breathing is one of the targets of intelligent ASV. So, having all this information on effectiveness, and I also mentioned, or I already mentioned, there's not so much information on safety, although I can say with my personal experience, I've never seen safety issues with intelligent ASV. Having said that, it was sometimes that I had to stop intelligent ASV because intelligent ASV is limited in the extreme situations. It cannot take care of all patients. Then sometimes we had to stop it and take over, simply because the ventilator was saying, I'm reaching the limits of what is allowed by law, what I can do. Now you have to take over the steering wheel yourself, but never a problem of safety. What about efficacy? First of all, I have to mention there are many studies that looked in some way at efficacy, but all these small studies were, of course, underpowered to give a convincing answer to the question whether these modes are leading to a better outcome of our patients. So Louise Rose, together with an international team, decided to do a Cochrane systematic review and meta-analysis, and recently she updated this systematic review and meta-analysis because there are many new studies in the field of the last 10 years. She had 62 randomized clinical trials in place, approximately 5,000 patients. These are not including the two most recent trials. I will discuss this a little bit later. And the primary endpoint of this Cochrane systematic review meta-analysis was duration of ventilation. So is it reducing the time spent on a ventilator? You can probably not read all this information, but the bottom line shows us what the systematic review and meta-analysis tells us, that is that with automated ventilation, there is a reduction in time spent on a ventilator. So it favors automated ventilation. Our findings favor the choice of automated ventilation. But of course, the question is, which of these modes were actually resulting in a better outcome? See that there is quite some heterogeneity. Could it be that it was only driven by some of the ventilator modes? And the answer to that is yes. Here you see the results for PAV+. This was a positive finding, a little bit less heterogeneity, still high, unfortunately, but this is suggesting that one of the modes, PAV+, is resulting in a better outcome. The same is true for adaptive support ventilation, as you can see here. Very high heterogeneity, I have to say, but the signal is quite strong. And intelligent ASV, so the more sophisticated form of ASV with a somewhat lower heterogeneity, is also showing a positive effect. So it's favoring the use of automated weaning modes or automated ventilation modes compared to standard of care. But this is systematic review meta-analysis data, and there are several problems with this. I'm not going to discuss every problem, but I think the only thing we have to do or had to do was to do a randomized clinical trial. As I sometimes say, the proof of the pudding is in the eating. How does it perform in a well-sized or adequately powered randomized clinical trial? And there are two studies I would like to discuss. This is the promising study, as was published in the New England now approximately a year or 1.5 years ago. This was a well-performed study. Well-performed study, large sample size. It had a beautiful run-in training phase, so all the centers were behaving equally and good. They used different types of ventilators, but unfortunately, the study was neutral in its finding. There was no difference with regard to the primary endpoint, which was time from randomization to successful liberation, and also with regard to the secondary endpoints, there were no differences, which is, of course, a little bit of a disappointment. Again, this was a very well-performed study. There are some secondary analysis going on. I don't know the details about that, but it's suggesting that there are other benefits of PAV+. So maybe the endpoint was wrong, or wrongly chosen. Maybe this was a finding because the control care was so good that it was difficult to find any benefit from the automated modes. But the answer is here to the question, is automated ventilation in the form of PAV+ better than conventional ventilation? The answer is unfortunately no, it's as good as. Two other studies. One is a very small study, which was actually stopped quite early. This was stopped early because of commercial reasons. I was partly involved in this study, EasyVent, which was a study initiated by Hamilton Medical. You remember maybe that is the company that is making the ventilators with ASV and intelligent ASV as their ventilation options. The study has never been peer-reviewed, or I'm not aware of any peer review at the moment. The data, however, are fully available at clinicaltrials.gov. The full report can be seen there. And if you look at the outcome, ventilator-free days, which is, if I'm still right, the primary endpoint of this study, you can see that there is a benefit, or there's a suggestion for benefit from intelligent ASV. But I would like to remind you, this study was stopped way too early. 62 patients, was meant to have something like 1,000 patients. It's coming from only 1 or 2 centers in Europe, and I think 1 center in the Americas. And it's with that way underpowered to come to meaningful conclusions. At the same time, in Amsterdam, we started another study, which is the active study, which was published very recently in JAMA, doing actually the same as EasyVent was doing. So we compared closed-loop ventilation with means of intelligent adaptive support ventilation versus conventional ventilation, which was either volume or pressure-controlled ventilation. And ventilator-free days was the endpoint of this study. It were patients that were expected to need ventilation for longer than 24 hours, and all these patients were included within 1 hour after start of mechanical ventilation. So no dilution of other forms of mechanical ventilation, or hardly any dilution, just less than an hour. And most of the patients actually started immediately after start of mechanical ventilation with the intervention. But you can see here already the results at the right side. With regard to the primary endpoint, the median number of ventilator-free days at day 28, there is no difference. So again, this is a neutral study. This is just another way of showing the data. This is usually how we now express ventilator-free days. You can see that there is absolutely no difference. And that's a bit unexpected, maybe, unless you say effectiveness does not always translate in efficacy. Here again, I show you how the ventilators behaved and how well the ventilators were with regard to the titration of the breath. Here, every breath is scored in the same way as I did in the last studies, where I showed this way of presenting the data with more patients, or I should say more breath, in the closed loop ventilation in the optimal zones as compared to the conventional ventilation. And again, on the bottom, you can see that it was reached quite early. So IntelliVent ASV, the automated mode of ventilation tested in this study, was performing quite well and very fast after start of mechanical ventilation. But again, it did not result in a better outcome. And of course, we did some secondary analysis. We had subgroups in the main study. We have now a Bayesian analysis of active, which is going to be submitted soon. I'm only showing you one slide of this. And there's one group in which it looks like the automated ventilation form is not performing well, which is in the neurological admission disease or neurological admission patients. And we do not have a clear explanation for that at the moment, although you can say that these patients usually are having another ventilation type. They are breathing more complex as the non-neurological patients, and it could very well be that the algorithms of IntelliVent ASV are not well adjusted or not well performing in these types of patients. But this remains speculative. There will be new studies with some more breath-by-breath analysis of these patients quite soon. The breath-by-breath collection of data, which is allowing us to look at waveforms, also allows us to look at how well IntelliVent ASV is preventing or affecting patient ventilator asynchronies. And in preparation of this, Laura Buitenman performed a Delphi study in which she was looking for which PVAs can be tracked by using the breath-by-breath data or waveform analysis without having an esophagus pressure catheter in place, resulting in what you see here in this figure. And because we want to do some weighing of the patient ventilator asynchronies or the different types, we wanted to have this scoring from the group to have later on in a reanalysis of our active study, but also other studies, a better idea of how well IntelliVent ASV is preventing PVAs. And you can imagine that some PVAs are maybe less occurring with IntelliVent ASV, but others may occur, and we need to have this information on how we should weigh these PVAs before we can move into that. This analysis is going on, and I hope to have an answer to the question soon whether IntelliVent ASV is reducing PVA, and then also with regard to which type of PVA, and could it be that it's also inducing PVA by itself? We have some evidence for that already, but we want to look in a bigger data set to have a better answer to that. So let me conclude with some slides on how the audience looked at the results of the two studies, especially the active study, which was presented in Melbourne a couple of months ago. There was a big discussion at the moment this study was presented about should we not have testing non-inferiority instead of superiority? And the question behind this, of course, is, well, if this mode is behaving at least as good why should we then not just use it? Because it's performing better with regard to effectiveness, and maybe it's even reducing the workload. I will spend some words on that on one of my next slides. And there was also discussion whether we had the wrong setting. So if you are in a high income setting like in the Netherlands and in Switzerland, where we had well-equipped ICUs with regard to nurses and doctors who were experienced in setting the ventilator, maybe it is impossible to have an automated phone mechanical ventilation mode to outperform them with regard to effectiveness, although that was not shown, but also with regard to the efficacy. So should we not have done this study in settings with some more limited resources or limited staffing? And this brings me actually to this last slide, or this last series of slides. You remember this one? This was one of my first slides. And on the top left here, you see, or sorry, on the left here, you can see that I had my questions about workload reductions. Is it possible that intelligent ASV and other automated modes reduce the workload? Well, actually, we have some information on that, and active will also be analyzed soon. This is the positive study. This was the very first study I showed in my presentation. Remember, this was the patients after cardiac surgery, easy to manage group of patients for a couple of hours, either receiving intelligent ASV or control. And what you can see here on top, the two panels on top, are the number of interventions done in automated group or the conventional group. But realize these are all interventions, meaning interventions done by nurses and doctors, but also the interventions by the ventilator, summed. And you can see from these two panels on top that intelligent ASV with nurses and doctors are changing many things. It's constantly red, meaning there are more alarms and more settings being changed in these patients. However, if you go to the bottom, and here we look what was only done by nurses and only alarms that nurses could respond or should respond to, you see that in the automated group, it's almost getting empty, and the alarm management is more or less the same as with conventional ventilation, although the statistics show us that it is less. So if you believe that workload is setting a ventilator, the number of interventions you have to do, or the number of alarms that you receive, then here we see superiority of intelligent ASV, as it is reducing, strongly reducing the number of interventions and alarms that a nurse should handle. So in conclusion, and this is then really my last slide, I'm happy to take questions thereafter or having a discussion. I think I showed you that there are several systems available. They are already in our system for quite a long time, by the way, and I see them in more centers being used over the last, let's say, 10 years or so. I discussed the effectiveness. I think these systems are highly effective. They are really outperforming nurses and doctors, which may not surprise us because we, doctors, nurses, we cannot take care of ventilation breath by breath, while these modes, these automated systems, actually can do this breath by breath. So our interest should go into the patients that do need our attention. We can really focus on those patients and just leave the ventilator doing the more easy cases, if you like that word. But even in ARDS, I showed you that on one of my slides, intelligent ASV is outperforming doctors and nurses. Now, the clinical benefit of these systems may be absent, as suggested by the large randomized clinical trials I discussed today, or small at best, but it depends on context, and it could very well be that in a low resource setting or with less nurses and doctors at the bedside, so with regard to personnel at the bedside, it could be that these forms of mechanical ventilation perform better than conventional ventilation. I'm not sure what the answer will be to the question, does it limit PVAs? I have some signal that it is reducing workload, but at this moment we are developing our secondary analysis, but also future studies to get a better answer to these questions. Does it reduce PVAs? Does it reduce workload? And with that, I would like to stop, but not after showing that we have a handbook. Leo Hunks and myself, we supervised a large group of authors publishing a handbook of invasive mechanical ventilation. This is already an old slide because just recently, a couple of weeks, the second edition of this book came out. It's from the European Respiratory Society. It's quite attractive, and of course I know I sound biased, but it's attractive because it's a book which is cheap, just some 35 euros, which is I think 3,500 Indian rupees. It's also available in an electronic form, and when you are in the electronic form, you have much more information than just the paper-based form. So I'm happy to help you if you want to order this. It's at the ersbookshop.com. It's easy to order, and it's even easier to use it online. So this is where I would like to stop and give the word back to the chairman. Happy to take any questions.
Thank you, Professor Schultz, sir, for such a wonderful talk, exhilarating talk, and I think you have shown so many trials, and it was a very nice analysis. So I think Dr. Lalit had a question. He said, if there is a tube block or a tube biting by the patient, then what happens on the ASV mode or the other modes, that PAV mode?
Oh, that's a very good question. Actually, it's behaving as if the patient is having airway obstruction, like apologies for that, COPD or exacerbation COPD. So you have to realize or understand that intelligent ASV is titrating the combination of tidal volume and respiratory rate to the the time constant. If the time constant is suggesting that there is a block or that the ventilation expiratory phase is taking more time, then it's reducing respiratory rate and increasing the tidal volume in a way to guarantee the minute ventilation. And as soon as that is gone, then the problem is solved. Then it means that respiratory rate goes down again or goes up again and tidal volumes increase. This is a good thing, but it's also a risk. And this is what I showed you on one of my slides at the beginning. It's our responsibility to recognize this because it could be happening unnoticed that the ventilator algorithm is already making the changes without us being aware that this is actually happening. And this is how we should deal with these types of automated ventilation modes, to have our alarms set in a different way, to make us understand that some problems are already solved. And this, the solving of the problem is not always adjusting the ventilator, but also solving, in this case, for instance, the blockage of the tube by sputum, or when the patient is chewing on the tube, if you understand what I mean.
Thank you for the answer, Professor Schultz. So then these modes have been around for quite some time, and you showed that also in your slide. Why are they not coming into mainstream? Is there really a lack of evidence? There's less research, we need more research, or is it that people are not comfortable because you got to reset your mind and to the new physiology? So if you can kind of clarify that, sir.
Yeah, I think there are actually several reasons why it is not yet mainstream, and it might not even become mainstream for some of those reasons. First of all, I think you know that PAV Plus is only coming at a certain type of ventilator or a certain branch, and the same is true for intelligent ASV. Intelligent ASV is only available on Hamilton ventilators. And if you don't have a Hamilton ventilator, you cannot apply it. Although I think soon it will be copied by other ventilator companies. So some sort or some form of intelligent ASV might become available. But I think that's not the only answer, or not the only reason why it's not used too often. And I saw from my experience, I learned from my hospitals where I have tried to implement it, sometimes successful, sometimes less successful, simply the belief that you cannot be replaced by a ventilator. You cannot be replaced by an automated mode, or even worse, I will always do a better job. And my answer there is, that's probably true, because you have interest in ventilation, you're an expert in ventilation, but you cannot be there breath by breath, minute by minute, day by day, taking care of your patients. So it's making your life easy. if you allow it to. But if you don't believe it, then you will not allow this into your system. And the third thing is, and that is quite surprising at the beginning, if you start using Intelligent ASV, it will take other decisions than you initially wanted to take yourself. And one example is just recently, we wrote a nice case report on that, and I think it will be submitted to your local critical care journal, by the way. Intelligent ASV, when it started ventilation in a patient with severe hypercapnia, it actually started to reduce the respiratory rate. And that is a decision taken by the ventilator, which is often overruled by the doctor. They will say, this is not acceptable to me. I'm not going to discuss this case in detail, but it's actually the opposite what happened. So CO2 or anti-CO2 in these patients came down for many reasons, by allowing a change in respiratory rate and a longer duration of the breath by breath. And this is something that people have to understand. Intelligent ASV, PAV Plus, is sometimes doing things that initially would make you move away from it. But if you start to work with it a little bit more, you will start to understand that actually some of these decisions are good. Also making it possible to use, by the way, without using Intelligent ASV. So it's also a way of education, what these most sometimes are doing.
Yeah, great. So thank you very much for the answer. So then just a final question. So you talked about proportional assistant and ASV, then we have NAVA also. So we have these three modes, automated modes. So if you were to, name one situation or one condition where each of these modes would be helpful in the future, looking at all the evidence that we have, what would it be, sir?
Well, that's a difficult question. I already mentioned that I have a conflict of interest. I worked for a year at the company that makes ventilators that produce or that have Intelligent ASV on board, although my connections to this industry are no longer there. My experience is also most with Intelligent ASV. So if I try to move away from those points and try to understand which one would I like most, I think I like Intelligent ASV most because it's active from the intubation to the extubation, while PAV Plus is only working when the patient is active. That's, by the way, the same for NAVA. If a patient is not active, so there is no diaphragm activity, then there is no NAVA active, or not that part of NAVA that you need. So that's one reason to think that Intelligent ASV will do a better job. The other thing is, and everything comes at a price, if you buy a ventilator and you want to use Intelligent ASV, you probably have to pay for that extra tool. But with NAVA, you need to have special catheters. And it could be that these special catheters are pricey in the country where you live. In the Netherlands, they were pricey, and my boss or my CEO actually said, we are not going to do this for all our patients, only in selective patients, because it's simply too expensive to use in all patients. So the short answer is, I think Intelligent ASV is the most promising one, or Intelligent ASV-like modes, but I'm not saying that the others do not work and might also help resulting in a better outcome.
Wonderful, sir. Really appreciate it, sir, and really thankful, sir, from all of us, from Young Indian Intensivist Forum, from all the audience which has been listening. We are very thankful, sir. Thank you very much.
You're welcome. Thanks very much.